Dr. Suneesh Kalliath, consultant interventional cardiologist, Kozhikode District Cooperative Hospital, Kerala. Today we can have a small discussion on the latest updates of hypertension. We know hypertension is becoming is one of the most common risk factors for non-communicable disease all over the world. As per WHO, nearly 63% of total deaths in India are due to non-communicable diseases, of which 27% are attributable to cardiovascular disease, which affect 45% of people in age group of 40 to 69 age. High blood pressure is among the most important risk factors for cardiovascular disease that we everyone know, and moreover, it remains poorly controlled due to low adherence and low awareness about the hypertension, lack of appropriate care through the primary caregivers, and obviously due to the poor follow-up and poor motivation from the patients. In India, the prevalence has also gone up to over 30 years to 38 percentage in men and 32 percentage in women in from 29 and 28 percentage respectively. Over last 30 years, it has almost increased about around 10 percentage according to WHO. Despite that, nearly half of the people, or about 50 percentage of men and 40 percentage of women with hypertension, are unaware of this condition. That is the most important thing. And another important factor is about 62 percentage of the men and 53 percentage of the women living with hypertension did not get treatment. And medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4, about 20% in men and 20% in women with hypertension. That basically, if we simply say only about one third of people who have hypertension are aware that they have hypertension. That means only one third is getting actually properly diagnosed for hypertension. And among this one third, only one third is getting proper treatment. That means they are getting the anti-hypertensive treatment. And among this one third, those who get the treatment, only one third is getting adequate treatment. That means everybody who get the treatment may not be adequate. So those among those who are getting treatment, only one third is getting adequate treatment. And again, among those who are getting adequate treatment, only one third is getting proper follow up over the time. So from this we can understand how simply this important risk factor is being overlooked or being improperly diagnosed and improperly treated. That is basically a component of both the patient and the physician. It is not properly diagnosed or properly counseled or properly treated from the physician side, and most importantly, it is not bothered by the patient because they are not giving proper weightage for diagnosing it or maintaining adherence to the treatment, because most important factor is hypertension doesn't give or doesn't have any symptoms. It is only a silent killer. So whenever a patient have any adverse end organ damage, then only they are getting realized that they are having this disease. That is the most important thing. And international study, the International Society of Hypertension, ISH, has released that ISH 2020 Global Hypertension Practice Guidelines. According to this, the inclusion of optimal and essential treatment paradigms attempt to address the issues that in resource poor settings. Optimal care refers to evidence-based standard of care, and where essential standard refers to minimum standards of care to allow specifications of essential standards of care for low resource. And ACCHA has released a scientific statement in 2021 offering new guidance for management of stage 1 hypertension among patients with low atherosclerotic cardiovascular risk. Among the low risk adults, that means no atherosclerotic cardiovascular disease, your 10-year risk is hardly less than 10%. With stage 1 hypertension, that means blood systolic will be ranging between 130 to 139 and diastolic between 80 to 89. Management starts with the non-pharmacological therapy. That is most important. If blood pressure remains uncontrolled at 3 to 6 months, consider starting a pharmacological therapy depending upon the suitability, had to start the medicine. That means initially you have to give a trial period of 3 to 6 months with an adequate or properly counseled diet and lifestyle practices. That is very important. As the literature says, if you reduce your weight by 10 kg, means excess weight by 10 kg, you can reduce your blood pressure by about 8 to 10 millimeters of mercury. So, according to this literature, like this practicing DASH diet, proper exercise, that is about 40 to 45 minutes of brisk walking per day, at least 5 days a week, etc. And properly you practice the diet with the low salt intake, low sodium intake, and with proper diet with more of fruits and potassium rich foods, you can try to reduce the blood pressure by around 10 to 50 millimeters per mercury. Even if you start antihypertensive treatment, for example, for telmisartan or calcium channel blocker like amlodipine, as the medium dose as the initial strategy, you will be able to reduce around 10 millimeters maximum. So before starting this antihypertensive treatment in stage 1 hypertension with those without significant atherosclerotic disease or less than 10% of 10-year risk, you have to initially try a proper dietary and lifestyle practice. That is important. That is one of the reason high. Next point is lowering systolic blood pressure targets down to 110 to less than 130 millimeters of mercury substantially reduce cardiovascular disease. This is actually highlighting our old, not old, relatively old spring data. That is basically elderly population of Chinese population. They found that if you reduce more the blood pressure, you can live more. That means there is good cardiovascular outcome if you reduce systolic blood pressure more. That was actually against the JNC 7 guidelines and all. So this data also says this is basically based on this step randomized trial that actually affirms the spring findings for the elderly people. And in this trial, there were around 8,500 patients of ages 60 to 80 in China. The invasive target trimmed 26% of the composite of cardiovascular risk. Now, a second major trial supporting lower the blood pressure target, better the cardiovascular outcome. That means you have to keep the target a little bit lower, maybe not 130 to 135, just 110 to 120, or even less than 110. Next point is with regard to the prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure. 2018 European guidelines on the management of arterial hypertension recommend that the diagnosis of hypertension should not only be dependent on office blood pressure, but also on out of office measurements such as ABPM or home pressure monitoring, that HBPM. 24-hour and nighttime BP measurements were associated with a greater risk of mortality and the composite of cardiovascular outcome. Thus, they may be considered as the most relevant measurement for estimating cardiovascular risk. For every 20 to 10 millimeters increment of blood pressure at the night, the risk of mortality increased by 23% and risk of cardiovascular events by 36%. This is very important because if you check the blood pressure in the daytime, that means office hours or during your clinic visits, majority may say it has blood pressure is in normal range. Or sometimes if you ask them to take the blood pressure in the daytime at home, that will be in normal range. But again, if they do it in the evening or the night, that may be higher compared than the daytime value. That is having significance. So this higher 10 to 15 millimeters of mercury than the daytime value has higher mortality risk. So here comes the importance of ambulatory blood pressure monitoring or continuous home blood pressure monitoring. If it is high, you have to definitely start the treatment either with a diet practice initially or with the medication. Next point is most patients with hypertension require lifelong medical therapy to achieve optimum BP control. 2018 European guidelines equally recommend 5 classes of antihypertensive drugs. Considering high non-adherence treatment, the importance of combination therapy is particularly highlighted to improve the adherence with therapy and BP control. So here the importance of combination therapy of different groups of medications as a single pill. That comes based initially from the data of European Society of Cardiology guidelines, 2018 guidelines. They recommend combined AC inhibitors or ARB with the calcitonin blockers or a diuretics for with the initial stage 2 hypertension. Next, coming to the next point, next recent highlight. Recently, early in 2018, products containing valsartan have been recalled worldwide with high suspicions regarding the carcinogenic effect of NMDCA, which was found in candesartan, irbesartan, and another group of ARB like this one, olmesartan, losartan, valsartan. NMDA has been classified by WHO International Agency for Research on Cancer to be a carcinogenic in humans. In 1 lakh patients found have received NMDA contaminated valsartan from one of the manufacturing centers which manufacture this valsartan, and every day for 6 years in a highest dose. It could result in 22 additional liver cancers over the lifetime of these patients. The presence of NMDA in these drugs could lead to 8 additional cancer cases in 1 lakh patients if they had taken the highest daily dose over the last 4 years. So, valsartan recalls accompanied by a significant increase in rate of emergency department visits over plus 6%. So, this is also a highlight regarding the carcinogenic effect of valsartan in the recent data or recent medical news. And another point, the Hygia study represents the largest study that tested nighttime antihypertensive treatment. So basically, there are different varieties of antihypertensive and different dosing and different combinations, and at which time it is ideal, evening or morning. So basically, this study highlighted the importance of nighttime antihypertensive therapy. In this trial, chronotherapy was associated with a significant reduction in endpoints, including the Hygia chronotherapy trial tested whether nighttime therapy in comparison to usual upon awakening hypertension therapy exerted a favorable cardiovascular risk reduction. The largest study included a total of around 19,000 antihypertensive patients. During an average follow-up of 6 years, 1,752 participants experienced the primary cardiovascular outcome. An ambulatory BP measurement was performed in 48 hours to collect the data on how BP different during sleep. Relative risk reduction for cardiovascular events was significantly improved from those with the nighttime treatment when compared with the awakening treatment. That is basically, we all know there is high chances of this early morning rise of blood pressure, and there is risk of major cardiovascular events like stroke, MI in the early morning hours. So, if you use a antihypertensive drug which is having 24 hours of action, if you take it in the morning hours, there's a possibility that by coming next by the time for the next dose, there is a chance of drug-free period of around early in the morning. If you take in the morning, so if it is in the evening, the chance of drug-free period in the early morning hours is less. Maybe that can be the reason that the more suitability of antihypertensive treatment in the late hours. So these are the some recent scientific data or recent updates on hypertension treatment. Thank you.